Going to go ahead and kick things off. Let's share my screen here. All right, so today Dr. Massey is giving us a talk on pain management. Go through a couple of quick intro slides here. This slide here just says that everyone involved in these trainings has no financial relationships to disclose. Funding statement, we have to show this here. We are a federally funded project. Grants come from the state opioid response from SAMHSA. It comes through us through Division of Behavioral Health. I think I see, I recognize a lot of the names on here, so people are probably pretty familiar with the CME process. It's pretty easy. Just a quick, get a quick certificate, or sorry, complete a quick evaluation survey at the end of the training, and your certificate will pop right up. You'll get that email, that link in an email. You'll also see that link to that evaluation survey in the chat at the end of this training. So for those of you who might be new joining us, Project ECHO, ECHO stands for Extension for Community Health Outcomes. So our ECHO is on substance use disorders and pain management. So we've got a hub team of 6 experts who provide ongoing trainings as well as consultations. If you're interested in a consultation on anything in the realm of pain or substance use, how to effectively treat patients with these issues, get in touch with me, and then I can connect you with one of our experts here. Those consultations are covered by our grant, and our experts are always happy to provide those. So we do these ECHO trainings in cycles of 4. So we're kicking off our first cycle here this morning, our first training in this cycle this morning, excuse me. So you can see our ECHO series here. We'll do these every other week for April and May. Then we'll be off in June, and then we'll come back again in July with another round of 4 trainings. And all of our trainings are conducted by our expert panel here, who I will let introduce themselves. So I'm going to stop sharing my screen, and I will just call on our team to introduce themselves. Let's see, Ed, would you like to introduce yourself?
Yeah, you bet. Good morning, everybody. Ed Kaiser here, nurse practitioner in Omaha, Nebraska. Been doing substance use now for just crossed over to 7 years. So excited about that. And also launched online treatment of alcohol use with the Sinclair method. So I'm excited to treat patients in that way too. So thanks for being here. Appreciate you guys.
Thanks, Ed. Mary.
Hi, I'm Mary Ellis. I'm an APRN and I'm also an attorney, and I've worked in Nebraska throughout most of the Omaha and surrounding communities for a really long time. So good morning. Nice to see you.
Good morning. And Alex.
Morning, Alex DeWarrick. I am a family physician who works at a federally qualified health center for 15 years now, about 8 years of substance use treatments, and also have an interest in infectious diseases. I'm glad to be here.
Thanks, Alex. And Stephanie.
Good morning, everyone. I'm Stephanie Bennington. I'm a psychiatrist. I kind of jump around all over the place. Was primarily in Nebraska, South Dakota, Wyoming. Now I'm going to be relocating to primarily just doing like the Rapid City and Chadron area. It's nice to see everyone this morning.
Awesome. Morning. Todd.
Good morning, everybody. Todd Stoll. I'm a psychiatrist, and I'm glad everybody's joined today to listen to Dr. Massey.
Thank you. And yeah, Dr. Massey, go ahead and take it away.
Guys, I'm John Massey. I'm a pain physician in places in Nebraska, and I'm happy to be here today. Drag you through some topics in pain medicine. Is it right with you, Will, if I start sharing here? Because it's going to take me a minute to figure it all out.
Yeah, you should be able to.
See how I do? Get this going into the slide.
Yep, I can see it. And then you can.
Does it look like a slide, or does it look like
yeah, you want to start the slideshow now, and then it should be.
How's that
Yep.
look? All right, guys. So we spend a lot of time, and we've had a lot of great discussions about kind of the intersection between pain and substance use and mental health conditions, and how those all interact in different ways. And and today I feel like part of what my task should be is to really describe the pain side of this world that we live in. We talk about the medications a lot and how under certain circumstances we're dealing less with sources of pain and more challenging kind of presentations because of the medical comorbidities. But I think that also undersells a little bit the the idea that so many patients are seeking relief of their symptoms as well. And so I'm going to kind of show you how this world is merging from our perspective as a pain specialty and how it fits in with some of the tenets that we're talking about with respect to multidimensional treatment, paying attention to the other issues beyond just the source of pain, and how I think we've really made a lot of progress and that I don't think people are fully aware of if they're only kind of peripherally involved in this population of patients. I'm going to build on kind of the other discussions we've had. If you remember in the past, we've talked in, if any of you have been on this, we've talked about the different types of chronic pain. We talk about nociceptive pain, which is a source of pain. There is a pain generator, so there's something wrong with a joint or a tissue or a structure that's abnormal, that's causing a pain signal. And nociceptive pain is kind of in acute pain, it's the problem. And in chronic pain, it's the spark that sets off this whole cascading of events that patients show up with. And that is the mood issues that develop, the exposure to medications with potential for abuse, the loss of quality of life and loss of function, loss of employment, family activities, and so forth. So I'd make the point that it's still very important to look at these patients in a holistic, multidimensional way. But the other thing that's also, I think, really important to understand is that in the past, in these kinds of disease states, so many of our options for definitive care were problematic. They were destructive to the body, they were destructive to the tissues in different areas. And so we used them kind of as an end stage. So people had a long time to develop problems. And I liken a lot of what we're doing in pain medicine right now to kind of the revolution that cardiology and cardiac care underwent about a generation ago. If you're really old, you remember that, back in the day, we could manage cardiac disease with nitroglycerin and medications, maybe keep people doing well, antihypertensives. But then it wasn't until the 60s and 70s that we developed cardiac surgery, where somebody could get a median sternotomy. You can open up their chest, you could take a leg vein or artery from their internal mammary arteries, and you could reanastomose blood vessels and then wire them back up and move forward. And that was really good at restoring blood flow, but it also had problems. It was destructive, it was invasive, it had complications that were associated with that. And we got really good at minimally invasive treatments. And now, if you have an aortic graft that you need to put in, somebody puts a catheter in your groin and they put a balloon up there and they deploy a big graft, and you can save the kidneys and you can save the brain and you save morbidity. People don't end up in the hospital for ICU for days. They can do very well with minimally invasive treatment, and that allows us to treat sicker patients, but it also of function. And we've got that thing going on in the pain world now. And I want to kind of show you what some of those treatments are because it's been a really fun time to look at this. I also want to remember that when we're dealing with these kind of conditions, under certain circumstances, a treatment directed at a nociceptive source, generating a tissue level problem is going to be very helpful because it's going to make the situation better. But we also have to remember that those more complex cases of centrally mediated pain, nociplastic changes, that is, the chronic pain is set in, there's different physiology. So now you've got the spinal cord and the brain involved in this. We can even address those in kind of a procedural yet minimally invasive fashion that makes this kind of a situation better. And I want to show some of these options. And this is a presentation that I have given a lot of time to clinicians, but it's a little bit of an advertisement for the field of pain medicine and what we're about right now that can help patients. So we're going to have to talk about just a little bit. We're going to have to talk about um, understanding the cause of pain. And the one I'm really talking about mostly, just to kind of make it a narrower topic, we're going to talk mostly about spinally mediated pain, maybe a little bit about orthopedic conditions, but I want to remind everyone that chronic low back pain is in the US every year. It's most expensive and of direct cost. That is what it does, what the frequency of it, the etiology or the epidemiology rather, the people who get it are usually young, active people. So the indirect costs are exceedingly high. And some people estimate it's more expensive to the US healthcare system than the other three major causes of pain combined. And that's really because it limits people's ability to perform in their daily activities. And in the past, we didn't be pursued. In young people, it takes somebody who can work and turns them into somebody who cannot if we don't have the right approach. However, now all of our primary conditions that we face with respect to low back pain, even early on, we have minimally invasive techniques. That is, things that we can do for somebody in a morning or an afternoon and send them home that day, and very soon they can get better, return to their normal function without any kind of big, large, debilitating recovery and or injury. But what's really needs to be based on is an understanding of what the etiologies are, and that's where I think we probably because of the understanding of this is new, and we didn't have an understanding of this for the last 50 years or so. There's a limited understanding of people who don't do this every day and exactly how we can define and how accurately we can define the nociceptive source of a pain condition and how we can make this better as a result. So I wanted to kind of walk through that a little bit with people. We see we see in chronic pain, people come in and they have low back pain and they say, well, I've got degenerative disc disease, or I've got arthritis of my spine, or I have stenosis, or I have what have you. You know, I've got arthritis. I hear people talk about this all the time, and frankly, that's not really not diagnostic in any way. Absolutely 100% of a degenerative wear and tear changes of their spine throughout life. The only people who don't are people who don't survive into their fifth decade, and sometimes people a lot younger than that. And so there's common sources for pain in the spine, and they present very differently. And if you kind of know how to look just a little bit to somebody, they're very definable based on how patients are complaining of their pain complaint. In our field is kind of divide people up into we talk about the three columns of the lumbar spine, the anterior column, the middle column, and the posterior column, just as a way to outline how we should think about this and what can be done. I like to talk about the anterior column, and this is really the most interesting one right now, because this is the most common cause of low back pain, is the vertebral bodies and the discs. Everybody, how many times have we heard, well, I have a slip disc, I have a pinched nerve from a slip disc, I have degenerative disc disease and what have you. And we've done for decades, we worked on discs, we looked at the discs and we tried to figure out, when do you treat a problem with the disc and what do you do about it? And very interestingly, lo and behold, about 10 years ago, probably about 15 years ago, really, we figured out that the disc and the interface between the disc and the vertebral bodies, we knew this was the number one cause of pain. We thought it was all about the nerves that innervated the posterior third of the disc itself. We could see the wear and tear changes, the dehydration of the disc. We could see the fact that it was developing annular fissures on the posterior element. We kind of thought of it like we thought of knee pain and hip pain, where once you start to lose the collagen structures of the disc was causing pain. So we tried replacing it. We tried doing lots of procedures for that, and we didn't get the results we looked for. Many times people are sent to us with anterior column pain, and for years people tried epidural steroid injections, and those give a little bit of relief like steroid injections do, but they're not intended for axial back pain related to the anterior portion of the vertebral column. And this is responsible for 50% of the pain. And the part about it that I think is really cool is that 15 years ago, we didn't understand that 70% of the pain from the disc and the vertebral bodies was coming from the nerve within the vertebral body itself, called the basivertebral nerve. That's a nerve that goes to the end plate where you get all the nutrition of the disc and the vertebral body, and it goes through changes when you get these step-by-step arthritic changes that occur in the anterior column of the spine. So these are patients, we've all seen these kind of people where they can't sit around for very long. If they sit or they ride in a car or they stand up or rake leaves and they're doing fine, but then the next day they say, oh, my back went out. I've got this terrible back pain, and they end up on their couch. They miss 3 or 5 days of work or maybe 2 weeks of work because they hurt. Anytime they try to do anything physical with their back, they can do it for a while, but as soon as they start to do it, it begins to hurt them, and they get this really debilitating pain. We see them in our clinic, and they're the people who are kind of like they're kind of like zoo tigers. They're kind of prowling around in the room. They can't sit down, they can't stand, they got to move around. They're very uncomfortable. It's very kind of a dramatic looking pain, and these people have anterior column or vertebrogenic pain. The second part of this, the middle column, these are people with sciatica or stenosis. Those are people who have radiating pain, radiating into their leg. These degenerative changes in the front and back of the spine are now causing an inflammation of the nerves that go into the leg. People with what they think of as sciatica or radiculopathy are very quick to go to the doctor. They're always sure that they're going to need a surgical treatment because this is serious, because it's going into their leg. And it's alarming. It's a patient who's probably had back pain for a while, and now it's going into their legs, so it must be worsening. So now they come to us and they need help. And the other presentation of this is something we call claudication and stenosis. And these are the patients who come to us, and they're typically older. They've had a more gradual on stickers, or they're riding around in scooters when they go to the grocery store, or they have walkers because they can't stand up straight and they can't walk any distance. And if you ever have a family member or somebody with stenosis, you know that what they tell you is, I'm fine until I stand up and cook supper. I'm okay if I'm sitting in my chair watching TV all day, but if I try to go and go to the grocery store, or I try to, work in my shop out in the shed for a while, I have to sit down to do it because it hurts to stand up. As soon as I sit down, it's all better. What medication do you have for this? Is kind of what they say, because they're like, I know I can't have surgery for this. I'm too old. I have, all kinds of medical reasons, but I can't do anything. So they end up sitting around not doing something. Huge loss of function, and that leads people to have problems with the rest of their health. And then the posterior element is something we call facet joint spondylosis. And these are people who come in and they have back pain early in the day. They typically have back pain because they've been doing some kind of athletic activity, or they wake up in the morning and they're really stiff and sore. They have popping. It's a little more common in the neck than it is in the low back, but these people talk about muscle pain and the muscle spasm that they get, and the fact that they get, they end up with medications of abuse. Particularly, they end up with all the muscle relaxants, the sedatives, because they need to relax their muscles, because what they think of as muscle pain is really something that's related to facet pain. So I'll talk about that a little bit. But the one that we're really, really thrilled about right now with axial low back pain that's related to the disc or vertebral bodies. It is literally responsible for 50% of the patients with low back pain, and it's very debilitating. And it's essentially because of what you get is inflammatory changes within the end plate. You get all these inflammatory chemicals that are released as a result of the wear and tear changes along the end plate of the vertebral body. And that wear and tear change along the end plate of the vertebral body leads to fibroblastic inflow, which then leads to change in the disc. You lose the elasticity, and when you lose the elasticity, you lose the mechanical activity of the spine, the protection that gives, and so you get a cascading event. Prior treatment for this, for anterior column or vertebrogenic and or discogenic pain has been core muscle strengthening, trying to support the spinal structures around there to try to minimize the pressure on that, which isn't very effective. It's typically not well tolerated by patients. And so these are patients who end up with fusion surgeries for discogenic back changes, degenerative disc disease, and what have you. And as we know with fusion surgery, that doesn't solve the problem. It just provides an architectural splint around that structure. You remove that disc, and now you've got what we call deafferentation pain, which is a nerve pain. So most of us understand that people who've had um, fusion surgery for degenerative disc disease and or end plate changes of the discs don't have a very predictable reduction in their pain compared to the morbidity associated with that. And it also leads to kind of lifelong changes in the spine. So that's been a problem for a very long time. And about 10 years ago, the procedure was developed called basovertebral nerve ablation. And it really required us to figure out that it was the basovertebral nerve by itself that was causing this problem. And so in this picture here, you see the nerves that are coming out along with the artery and vein supply of that vertebral body that then goes to the disc structure itself. And what we figured out is, and this is an axial view of that here on the left side, what we figured out is that if you put a probe into that spot, it's very much like having a vertebroplasty performed, but you put a needle through the pedicle, and then you put a little probe there where the root of that nerve is, and you ablate it. You provide an ablation to that, and you basically permanently denervate that half of the disc in that vertebral body. So what you see on the right side, you see what are described as modic changes. And you see the inflammation around that L4-5 disc. This is pretty severe, pretty notable. Surgical treatment for that in the past would be to provide a fusion surgery, either go through the abdomen and do an anterior spine fusion, or you can do a lateral, or you can go through the pedicles and fuse that. And that treatment can provide, you change the movement, you prevent movement about that, but it really doesn't do anything for that inflammation. We've had a few cases here lately where somebody's had a persistent back pain for a decade after a very successful fusion, and we look back and we still see these modic changes at that fused level. If we go in there and we ablate that nerve, it's basically a thermal lesion that we provide that heats up that nerve and essentially just deactivates the basovertebral nerve that has really no function other than to give us pain at the disc end plate structure. We make this pain better and permanently. It's a procedure that takes about 15 minutes per level, and we have to do 2 levels on this picture on the right. And we do that, and these people come in, we give them a little bit of sedation, we ablate that nerve, they go home, and then over the next 2 to 4 weeks, that nerve just convolutes, it just basically dies off, and their pain goes away. They don't have any limitation on their function afterwards, and they return to normal activity without any risks of further harm. So that's a procedure that's really been interesting. And what's funny about it that to me is that because it was so revolutionary with respect to how we manage this condition, there was a lot of work that needed to be done to prove that it was effective. And so the part about that's been really interesting is that they have tons of level 1 data that supports the long-term improvement of pain in these individuals. You see, this is known as the Intercept study, and it was first 24 months. Now we're out. I believe the recent data coming out is we're now out 8 years. And what you see is a reduction in VAS in the mean of about 41 points out of the 1 to 100 scale, or 4. So people come in on an average of 7 out of 10 pain. After 3 months, when the effect of this works, they're down to 2 or 3 on average. That's a persistent. And the other thing that's noted is about a third of patients who get this procedure are going to be important is to understand the change in their disability index. That's the ODI here. A 30-point reduction in the Oswestry score, a disability index, essentially means that if somebody comes in and their ODI score, let's say, is 50 and they come down to 20, the lifelong change in that means essentially about 70% of the jobs in the country you could not perform, or 60% of the jobs in the country with an ODI of 50 or above. And if your ODI is 20 or so, there's no limitations on your ability to be employed. Activities of daily living, these are people who return to normal activity that's not limited by pain. So the functional data alone really supports the idea that this is going to be a very important treatment, because what it does is now these people aren't limiting what they can do. They're not changing their lifestyle. They're not getting unhealthy with respect to developing worsening heart disease, obesity, diabetes, and what have you, because they can return to normal activities. And then the other part about this is that it's now been replicated in multiple studies. I think at last I saw there's approximately 40,000 patients enrolled in level 1 studies, and they all tend to show the same thing. That is, you get a third of patients get pain-free. You get a VAS, that pain scale, that from almost 7 down to 2. Their disability index reduced 26 to 30 points, and quality of life improvement is correspondingly great. This is with a 30-minute procedure that we do once and never have to repeat. So this is a very exciting time to be working in that area. There's another kind of competing procedure that I just wanted to bring forward because it's really interesting. It's a different way to get at that same condition, and this one focuses on restoring the mechanics of the disc. And this slide is talking about the Viadisc procedure, and on the left here we have the various grades of wear and tear phenomenon within the disc end plate structure. So on the top left, at the top of this is the disc that we all would want to have, or that we have when we're teenagers, and we go through these changes as we go through the columns and rows. On the left side, we're grading the degree of wear and tear of the discs and how they move down until you get to the bottom where you see these degenerative end plate changes. They look like little hamburgers at the bottom. You've got the fibroblastic ingrow. You've got inflammation that's easy to see with the MRI technology. These people are undoubtedly going to have some discomfort. But what happens up top early on are the discs are starting fibroblastic wear and tear, the changes at the end plate that those last slides were showing you. And that's because when you get an annular tear, which occurs just kind of as like an ankle sprain, if nothing else, you just twist your back. And so the back of the disc gets a little bit of tear in the collagen fibers. And then the structure of the inside, the nucleus, leaks out temporarily. It's very painful in a short-term fashion, but more importantly, it's like walking on a flat tire now the rest of your life. So a young person who gets this kind of a problem because they say they did something while working as a firefighter or at an athletic event or something like that, they're really in trouble, because we're going to move and progress towards those end plate changes that I was seeing and talking about in the previous slides. Now what we can do, however, the Viadisc procedure is basically cadaver allograft. So at the University of Miami, which is kind of the world's best tissue bank, what they do is they harvest cadaver nuclear material, they dehydrate it, irradiate it, and what we do is we take it into the operating room and we rehydrate it and we inject it into the disc. And what we found with that is, because it's made of this very complex glucoprotein structures, just a big molecule that's got proteins that capture water, and then it acts as a spring for the spine structures. That's how the disc works. And when we put that in, rather than other substances, we put that in there, it stays in the disc. It makes the disc work, so then you don't develop those fibroblastic changes that we were talking about with the vertebral end plates. So you can forestall that. Once again, this is just an injection that we put in one time into the disc. It sort of pumps that back up, and our data on that shows that we get long-term resolution of pain by restoring the mechanical structure before it develops problematic changes that lead to those other conditions that require the intercept. So two very simple, minimally invasive techniques that we have that now can restore the most common, restore the normal lumbar spine function in the most common cause for axial back pain. And we're finding that this works great. It works very effectively for patients, but the trickiest part about it is generally people aren't aware of the success that we're having. And so we're really having to kind of redefine the whole algorithm so that people understand that we can really make them better before they develop all the problems that later on occur to the issues that we have to talk about with respect to chronic pain, substance use, and what have you. This one's a little bit more common, and people, I include this because I think people may be more aware of this, maybe not, but facet joint pain is probably the second cause of low back pain. And we've treated this with a longer period of time with something called radio frequency lesioning. And really the kind of person who has facet joint pain, they talk about they get discomfort when they move their back. If they extend their back, they have pain. So sometimes they have pain at night when they're sleeping. It's kind of an arthritic condition that occurs even earlier as we get some arthritis of the facet joints, which is where all of our motion is in the spine. And the problem with that is that because you get this because you're kind of subconsciously splinting, and when you stop moving those joints, you much more rapidly develop additional arthritic changes. And as you develop those arthritic changes, now it translates into the anterior column, like what I was talking about. Very common in the neck because our neck is about motion, and our lumbar spine, the angle of the facet joints prevent some of the motion. But people, you've heard for many times people talk about, I get this pain in my neck, I've got a pain in my shoulder, those muscles are really sore, and then I get a headache that starts in the back of my head, and then later on I get a migraine. You can hear all the kind of the problems that cascade from that. What we do with facet joint treatment, though, is very successful and easily managed. Studies were done in the early 90s rather, that identified where the nerves are to these facet joints. They're called the medial branches because they're the first nerve that pops up out of that spinal column off the radicular branch, and there's two nerves that go to every joint, and we know where they live, and we can identify them on fluoroscopy structures. And so what we go in and do is we put a little bit of local anesthetic where we believe those nerves are, and we numb those nerves up, and for a brief period of time, a patient says, "Yep, that's it. I feel great." We don't numb anything but that medial branch nerve with just a bit of local anesthetic. And what that does then is it proves to us that this is the source of the pain. So what we do from there is we go in and we put a needle under fluoroscopy, and these needles then we heat that up to 80 or 90 degrees, which is kind of think of it as that's a Celsius degree, so it's enough to denature the protein. And what we do is we demyelinate that nerve. We melt off the myelin sheath on that nerve, so it inactivates that nerve to the facet joint. So while that nerve is demyelinated, which is very often a year or more, that structure doesn't have any pain. And now when you move that joint, it doesn't hurt. So naturally people start to move those joints. They I like to say, they sand those joints off. They get better motion. The only other thing that nerve goes to are the multifidus muscles, which are the deep muscles that lie in that area, which are responsible for that I need a back rub kind of sensation in the trapezius. That's really referred pain from the arthritic facet joints. So radiofrequency lesioning, which was originally something that we did for intracranial tumors in the 50s, we now have used for the last 30 years with very good success for facet joint pain, which is kind of the second common cause of low back pain. And sorry, this is the data on the Viadisc. I put these out of order, but again, you see what we get is a reduction with that treatment of really taking somebody from a pain score of 5.5 or 6 down to 1.5. And on a disability index is essentially fully disabled with respect to the spine down to 18, which means you can pretty much do anything that you were able to do prior to having your condition. So I'm going to go back here to kind of talk about that. So now we've talked about the anterior column and treatment for that. We've talked about the posterior column with radio frequency. The middle column is the one that's always been tricky, and that's radiculopathy. We have very successful treatment for radiculopathy and or sciatica in younger individuals. Decompression surgery works if epidural steroid injections work. Most of the time, we get relief of those symptoms pretty quickly. The one subset of that that's difficult are those patients I talk about with stenosis, and they're developing problems within their spinal canal at multiple levels that are sort of insidious. Now they have that pain that I mentioned where if you try to walk, they can't walk, they can't stand up for more than a few minutes, and they can't participate in life because of that. They're either using a walker or a wheelchair, and what happens with that? And so we developed a mild procedure was developed. And the challenge in the past has been from a surgical standpoint, what really occurs with this is because of the subsidence of the lumbar spine, the ligament, which is up and down along the spine, it kind of, as the sits down, the ligament, which starts out nice and taut, now bunches up. It's not a structural problem, but it's a hypertrophy of the ligamentum flavum. And so the picture on the left is an axial view of the spine, and that little V there, that black V, that's the ligament that's crushing that narrowed down triangle, which is the spinal canal. And on the right, the yellow, that V-shaped yellow is a depiction of that hypertrophied ligamentum flavum. And what that gives patients is it's like claudication that people get when they have bad blood vessels into their lower extremities. If they're sitting down, they're fine. If they stand up, they're okay for a period of time. Usually it's a couple minutes, sometimes it's 5 or 10 minutes, but it's not enough that they can do anything. They don't go to church. These are people who don't stand when they're at church because if they stand, they start to feel like they're going to get weak, so they sit down. People who don't go to sporting events, people who don't go to the grocery store, or if they do, they need to lean forward on their grocery cart to even get, a gallon of milk and get back to their car. Surgical treatment in the past, medications don't work for this, injections haven't worked for this, and surgical treatment has always been a challenge because those people have this problem developed at multiple levels, and if you go in from the side, from the foramen and open that up, you have to get through the pedicle. You basically destabilize the spine. And if you do that too much in order to get that ligament out, you have to fuse that in order to maintain the stability so you don't develop worsening problems. And since that occurs at multiple different levels, and mostly because of medical comorbidities, largely osteoporosis, bad bone density, poor body habitus, and what have you, these individuals aren't candidates for fusion surgeries, certainly not at multiple levels. Or if they get that fusion surgery, they're not going to be better. So somebody with stenosis who has pain when they try to walk or stand, if they end up with open surgery, the risk would be that now they have pain all the time. So surgeons very, reasonably avoid treating that, worrying about treating that in a lot of instances. What we can do though with a mild procedure, let's see if I've got a better slide on that. No, what we do with the mild procedure is we can go in with a needle. And since we can use a different approach, we can go in with a needle and we can just suck out that ligament. And part about this is that the risk of this is the same as just an epidural steroid injection. In other words, since we're going in with the needle and we're not invading any structural area, when we pull that ligament out and just open up breathing room for that spinal canal, these individuals really go home, and within 2 or 3 days, they're back to themselves. They feel better. Sometimes they have a little bit of soreness from a needle spike, but after a bit, they get a dramatic improvement in their ability to stand and walk. The studies on this are really fascinating because we've got now level 1 studies that show we get long-term disability improvement, we can improve people's ability to stand and walk. And what that means is, when you're talking about a 7-time increase in standing, if somebody can only stand for 5 minutes or 10 minutes, now they can stand up for an hour, they can make dinner, they can go for a walk, they can go to church, they can go to the store, they can do their activities of daily living, and they're able to return to kind of their um, claudication life with a procedure again that just brings them into the OR for typically 20 or 30 minutes, and they go home that day and almost immediately start to get a benefit. The other part about this, it's really interesting, is that less than 8% of people that ever have a mild ever require additional surgical treatment for stenosis, and that compares favorably with the reoperation rates on people. So if somebody does have a open decompression because they maybe have this stenosis at one level, decompression after an open laminectomy, reoperation rate is about 5.5 or 6%. Reoperation with a mild procedure, which is much less invasive and has the opportunity to go to multiple levels, is just slightly greater. And they believe that that difference is probably the fact that we pick people a little bit more quickly to do milds on, because we know that we're not doing something that's potentially destructive and potentially can lead to the need for a fusion surgery. So you get the concept that now, if despite what's going on with a minimally invasive procedure, we can reduce the debility, the functional loss, as well as the pain that's going on with these individuals. And I, I really read a lot in this setting with the echo presentation. How many times are we talking about an individual who's been given medications, an older individual, they're being given medications of abuse. We're worried about what's going to happen to, our family member who's maybe at home alone. They're having this problem. They can't walk. We're giving them gabapentin. We're giving them muscle relaxants. We're giving them, low dose opioids because they don't tolerate much, because they can't stand and walk. And medications really are many times I should have something done. Why don't we just try to be conservative about this? And the risks of conservative treatment in cases like this are just much, much higher than the risks of definitive care, because we can do this for somebody, get them back in their environment, and now they're able to successfully go through their day. There's another treatment that we talk about with Vertiflex. I include that here. In some individuals, the reason they get that collapse of that level is that when they stand up, they actually get an extension because of that loss of integrity of that lumbar segment. That when they stand up, what's happening is they're extending their spine inadvertently, and that's why these individuals then lean forward. And you see, they'll be on the grocery cart, leaning forward on a walker. If they're leaning on their counter, they can get some relief of pain, so they'll walk a distance, then they'll lean, and what this Vertiflex procedure is, it's just the needle. We slip this needle in, and through this tube, we place this little device that then we deploy. It's made of titanium. It opens up the spinous process, and it buttresses them open. So now we can open up the space, not only in the central canal like this prior picture was showing you, this one, but also in the foramen. So with foraminal stenosis, now we can just open that up. And the part that's very nice about this is it's fully reversible. So if it provides a great deal of relief, it does. It's there if if somebody develops a further problem, it's something you can just take out very quickly without any long-term difficulty, and it doesn't change any structures. It just holds open those spinous processes. So then, in our world, which is the right procedure to do for these stenosis patients is a little bit difficult to understand, but functionally what's going on is we're opening up that canal in the middle here with those red parts with the mild procedure. And if you have more stenosis laterally because of the facet joint hypertrophy that's in there, or the disc structures, what you have a little bit greater opportunity to open that up with the mild, or with the Vertiflex rather. So, but but again, this is long-term data and level 1 studies that show that we get 66% improvement in back pain, 75% improvement in leg pain, 85% reduction in opioid use, and 90% patient satisfaction. We probably need to really understand that our patients don't want to be taking these medications that aren't working, right? They're taking them because they can't find another answer. And we provide them another answer. Most importantly, if we provide them an answer that improves their functional status, now they can, go to the sporting events with their grandkids or their kids. They can go on vacation. They can go to church. They can go to the store. They can be independently living. This is a very meaningful improvement in the functional ability and quality of life for these individuals with something that's minimally invasive, has essentially no risk, and they can go home quickly. I probably shouldn't take too much. Yeah. So the data on this is robust. The reflection I have on this is really what we have is level 1 best quality data that shows superiority of these treatments compared to prior treatments, both with respect to effectiveness, cost effectiveness, and in restoration of quality of life and improvement to be active. And these companies, to their credit, they invested, essentially hundreds of millions of dollars to show that this is something that will change the algorithm, change the paradigm for very common conditions that we have. And what we'll get is improvement in functional status as well as improvement in quality of life via pain reduction. With fusion surgery, individuals will end up with other conditions, have SI joint mediated pain. We've really struggled for a long time knowing how to treat that. One way to treat that is injections. One way to treat that is fusions. We can do lots of different fusions, but now we have even more minimally invasive fusion treatments. And this on the right here is an allograft. It's basically an allograft bone. And what we do is essentially put just a slightly larger needle into the joint, and through that needle we just tap in this bone dowel, and it effectively, two of them, and it effectively fuses that SI joint. I include that here because the acuity of this is very minimal. We can do this in an office procedure room without any need for sedation. It takes about 10 or 15 minutes to put it in there, and immediately patients go home and they're feeling better and with persistent relief after an SI fusion. Another kind of stimulation. So now we're just talking about the other kinds of pain complaints and minimally invasive things we can do. People are aware of nerve irritation. Maybe somebody's had surgery and they've got a groin pain after an inguinal hernia. Maybe they've got really bad knee pain that occurs after a very successfully performed knee replacement. What does our data show that about a successful procedure? And so once you get that nerve pain that becomes nociplastic pain, you get this increasing pain. Medications can help that, but one of the things that we really can be very successful with is this is a DRG stimulator. And what you're seeing on that picture on the right is two wires that we thread where the ganglion is for the nerve, in this case at the L5 and S1. So this is somebody with probably ankle pain after a successfully performed ankle surgery. We put these little wires in there, we hook them up to a device. They don't even know that it's on, but it reduces, up to 80% of their pain quite successfully without any challenges, with improvement in quality of life. And this is even more effective than our traditional spinal cord stimulation that we've used for years. Getting to some kind of harder to understand kind of conditions. Now let's imagine we've got somebody who's developed more degenerative changes in the lumbar spine. They've had years and years of back pain, and they're getting muscle spasm. And we look and we see that they have spondylolisthesis, which is now the structure of the spine has degenerated so much that they're getting a little bit of a slip of one vertebrae on another. And these are often people who are deactivated, they're overweight, they have multiple levels of problems. So a surgeon looks at this and says, "You are not the person I want to treat for the surgery." We that activities muscles, which are essentially smooth muscles. They're not under conscious control. And we can see under imaging that they develop atrophy as people develop wear and tear changes. And so those muscles, so it's like now they're two-legged individuals rather than three-legged because they don't have any activity of their multifidus muscles. And we can put a little stimulator in there, and it doesn't provide relief, but what it does is it stimulates that muscle 30 minutes twice a day. And what we see is, despite the fact that we can't change their spondylolisthesis or their chronic multi-level degenerative disease, we can reactivate those muscles so they now support the spine. So over the course of 3 to 6 months in a permanent fashion, like you see here, we can reduce the back pain that comes from that muscle dysfunction. And that's also now, that data is also out 8 years, and the people initially treated with that are still getting this level of reduction in their pain. I think maybe this is the clinical outcomes for Reactivate are similar in that we essentially get improvement in activities of daily living. We get improvement in quality of life that results as well as reduction in the use for any kind of medications, not just opioids, I would add. Last thing I just kind of want to bring in here is radio frequency lesioning for major joints. How often does somebody come in and they say, "Well, I've got really bad knee arthritis, but I'm too sick, or my surgeon won't let me shoulder or a new hip or a new knee." And what can we do? And years of lack of success, I should say, with steroid injections into the joint, which accelerates arthritis developing, and particularly problematic are people who have both stenosis and shoulder pain. They can't walk because they're stenosis, and they can't use a walker because of their shoulder pain. Well, what we can do is with a single treatment, we can ablate the sensory nerves to their shoulder joint. So now, despite the fact that they have arthritic changes in their shoulder, we can make that better simply by lesioning the sensory nerves without any effect on any motor nerves. So all we do is we make that numb. Additional ways we can get at this is peripheral nerve stimulation. These are little temporary devices that we put in. On the left, you have a Sprint PNS, and that's a device that we just put a little wire through the skin. It's got a special covering so it can stay in there for 8 weeks without developing any skin infection. And we have an external battery, and it stimulates the nerves, in this case on that picture to the shoulder. So they're getting this low-level stimulation that they don't really notice what's going on, except it reduces their pain. And what's fascinating about it that really kind of validates our understanding of the physiology is we put those wires in for 8 weeks, and then we take them out at the end of 8 weeks, and they get a year's worth of relief with that temporary device. So what we do is we neuromodulate, we kind of provide positive neuroplasticity by reducing the neurals coming from that arthritic shoulder or joint or structure. And after 8 weeks of retraining that nerve, when we take out that wire, they get 10 more months on average of pain relief with that. If it returns, we can either repeat it, or on the right, we have a NALU peripheral nerve stimulator that's permanently implanted little wire that we put in this disc they wear on the outside. It provides that stimulation, and it can be lifelong. All right. I think that's enough talking. I probably used up more time than I intended, so I apologize for that.
Not at all. Thank you, Dr. Massey. Okay, we got a few questions if you have a few minutes, and if people need to hop off, feel free to do
Okay,
so.
let me see if I can.
There is a link in the chat to that evaluation survey. If you want to grab that now, that'll also come in an email. So the first question for you, John, is can nerve ablation also be
Yeah.
done on the cervical spine?
Yes, nerve ablation is Well, as a matter of fact, about 70% of the time we are doing it on the cervical spine. That's because, like I mentioned, the motion of the spine means that the facet joints wear much faster. Um, so, so we do it very frequently in the cervical spine. Actually, all of these treatments can be done in the cervical spine. I was just kind of using the low back as kind of as a as a descriptor. Yeah.
Next question, how is a specific vertebral
Next
level
question, how
identified?
the
Yeah.
specific vertebral level identified? What we're looking for are modic changes. Modic changes are kind of a plus minus phenomenon. It doesn't matter how severe they are. Once you see modic changes, you know that there's inflammation in the end plate, and you relate that. And then we do some examination findings that corroborate that. And what we ultimately end up identifying is what level, and we'll treat the levels that are involved. Yeah.
Excellent. The last question I'm seeing from Denise, she asks if there's a specific resource for to refer patients for evaluation for these procedures in Nebraska, especially in central and western Nebraska. Alex provided some options there. Denise is specifically in Kearney. Any recommendations for her
Well,
there?
I would give a little different recommendation. I like to do these procedures, and I'm in Columbus and Fremont and Lincoln and also out west. I practice at Regional West. So my practice and my partners, we perform this.
And so yeah, your practice is MD Payne.
Yeah.
And I'll throw in a link to MD Payne here in the chat. So you can check
Yeah.
Dr. Massey out that way. Let's see. I don't see any other questions, so we can call that a morning here. Thanks so much, Dr. Massey. And see, and then we'll be back in a couple of weeks. Todd will be leading the way um, in a couple weeks on a talk. So hope to see everyone then. Thank you.
Thanks, guys.
Thank you.